realized that the ISUOG guidelines have been revised. There was an initial first trimester guideline in 2014, and I think the more recent one is 2022, 23. So what are the new features of the new guideline?
Thank you, Ahiga. Yes, thank you, Ahiga. So I think I was already alluding to the fact that we have created 2 levels of screening because we have acknowledged the differences in practice across the world, and we have created the minimum requirements for basic structural survey we have included a very clear table as to what should be included in this basic screening, and then we've expanded to describe the best practice for comprehensive detailed examination as shown in Ravi's ultrasound demonstration. I think that is to give guidance as to what I think is important for us to first state that this is a minimum requirement, and then what else we can do. Then another feature that is very important for me, which is we've been advocating for, is to add the screening of preeclampsia within this 11 to 14 week scan, and we've made it as part of this guideline. So I think these 2 main features are significant. I wonder whether Ravi wants to add anything to that.
Yeah. Yes, I want to add some words. You know what happened when we were discussing online the new criteria, what are going to be included. In the past, we had a table saying obligatory and optional. So for example, they were putting 3 vessels optional, 4-chamber view obligatory, lenses of the eyes optional. And we said, we should, as an ISUOG for the whole world, do not tell what is optional. We should tell them what can be seen in all fetuses, and we have a long list, as I showed you today. I'm sure not everyone will be doing all this list, but this is what I personally do, and this fits to the comprehensive examination. So if there is a previous history, I will focus more on some details, period. Now, the next aspect was, but what about an IPT? And in many places in the world, I feel, and even Germany, that many doctors are saying, I don't need nuclear scan anymore because I'm doing an IPT. And we said, stop. And I said, but I sent you the patient in 22 weeks. And we had, I showed in ISUOG, within 1 year, 2 cases of anencephaly at 20 weeks. And we said, no, this cannot be the modern approach to medicine. And instead of saying in our requirements, we need to rule out anencephaly, holoprosencephaly, exomphalos, and so on and so on, we said it another way, say, oblige the people as minimum requirement to measure the BPD, to measure the CRL, to rule out any small baby, to look at, they say, the stomach, to look at the limbs. And this way, you are indirectly observing them, at least as minimum requirement, that no of these obligatory anomalies can be overlooked. So this is why it should be our wishes that one day the patient come and say, I want an IPT. Said, okay, but let's have a look. We measure the fetus, we measure 2-3 things, and indirectly we rule out the obligatory thing Singalaki has ruled out. If there is a risk, or if there is, like in the USA, you have an indication list, or if the specialist is scanning, then they will go as I showed in my presentation. I made one mistake in what was saying. I was saying the brain stem should be slim in comparison to the distance over the brain stem. The distance, I said in my presentation, the distance should be smaller, it should be larger. There is a question. What's your take on axial assessment of the nuclear translucidity compared to mid-sagittal assessment? Never. I use it, let's say, I do it, let's say 1 out of 20 cases or 30 cases, only when she had already some, let's say, an IPT, for example, she comes for a scan, and you can only assess transvaginally, then I will do, but I will try always to get a view. And then when I do the measurements, I think in my mind, I hope Kipros is not watching me, he will kill me.
Well, I think the trouble with this axial approach is that we haven't defined the landmark to determine the level at which you must measure the fetal nuchal translucency thickness, and obviously you can choose a thinner part to record it because you want to avoid so because it's a very, very long part along the neck of the fetus. So I think if we haven't got a standardized approach for such a measurement, then we should not be measuring the nuchal translucency axially. But then, yeah, sometimes I would look at it for both mid-sagittal plane and then and axially, but then but I wouldn't measure the NT at that plane because I don't know where to measure.
The only exception, Leona, is when it is really very thickened.
Oh yeah,
and it doesn't matter actually if it's 6.5 or 7.2. So I measure because I went transvaginally. I measure, let's say, something to say it is thickened more than the severity.
Yeah. There's another question. I think that's for you, Rabbi. When do you do the first trimester anomaly scan transvaginally? Do you measure even the uterine artery PI transvaginally, or do you change it to transabdominal approach?
It is actually even more easier to scan the transvaginally because when you are there, you can switch to look at the cervix and you tilt slightly to the right and to the left, and the arteries are there. So exactly there where you find them. And if you remember when you have done a surgery on uterine and uterus and removed and you cut the uterus, it's exactly there close to the cervix. So by far it's easier. And what I did, you agree, yeah?
I agree, anatomically it's easier, but because it's much easier to identify the vessels. But I find it difficult because we have seen the data from Ritsuko demonstrating that the differences between the PIs measured transvaginally versus transabdominally is greatest when you actually have a high value measured transabdominally. So the trouble we have is that we might end up underestimating the PI if you measure transvaginally, but you wouldn't know because you haven't done it transabdominally. So I worry that you will end up having a false negative case. So I think if you do not know, how can I say whether this is an underestimation? That is my that's my concern.
What I do in my everyday's work is I start abdominally and try to measure the nuchal, the CRL, and everything else. So if it comes that it's really almost quite difficult because adipose patient and so on, I will add to my measurement the uterine arteries that I finish with this and then move to the transvaginal and scan anatomically the fetus vaginally. So if I don't see anything, of course, I have no chance.
I wonder whether Dr. Higa, are you still with us? I know. Oh, fantastic.
Yes, I am.
Sorry, I wasn't sure whether you're. Do you have any comments? Because obviously in your setting, and I wonder how easily it would be for you to implement our latest guidelines.
Yeah, there are obvious challenges. One of the best challenges, which I usually will talk about, is the issue of the health system. Our women very rarely come to the clinic in early gestation. So most of the women that you see are usually in the second trimester. And that's the earliest time that you get to see some of our patients. So occasionally some of these guidelines may not really work for the majority of our clients. The modal age for presentation in the clinic for booking is usually in the range of about 16, 18, and 20 weeks. And that's even in the high-end centers. So that's a challenge with the implementation of this. That does not in any way exclude those women who come in quite early. There's a higher chance of women who had a previous mishap in the pregnancy coming in early for booking. So those are the ones for which many of these guidelines could actually be implemented. So those are the challenges. However, as we said, it doesn't exclude the fact that there are some women who would require the management in early gestation. Now, the issue of transvaginal scans, and from what Rabbi says, seems to be a routine in his assessment of early gestation. That again poses a challenge because of competence and training. Obviously, I'm sure Rabbi would not ask every person, every sonographer to stick in a probe into a woman's vagina in early gestation. So occasionally too, those are challenges, and the issue of competence is something that must be considered. So most of the scans that we do in early gestation are actually transabdominal scans. And frankly speaking, most of what he has spoken about, especially the very relevant ones, and real gross anomalies, diagnosis can be made in competent individuals on the transabdominal scan. I would want to just ask, probably Rabi or you, Poon, what's your view about routine assessment of the cervix in first trimester ultrasound scan?
Leona.
Yep. So are you referring to the cervical length, or are you referring to
cervical
the
length? Yes.
Okay.
Not the anatomy, cervical length.
So basically, we do know that the measurement of cervical length at that time point is somewhat predictive of spontaneous preterm birth, but then the screening performance is far from optimal. It's not the same as compared to the second trimester assessment, and therefore, at the moment, we're not recommending the measurement of cervical length for routine screening at the moment. And I think the trouble we have is on two issues. One is the approach to measurement. As I think when at that time point we have the isthmus, which is going to evolve into the lower segment, and so actually I find well, for me, I with the use of high quality ultrasound, I will be able to differentiate the endocervical canal from the isthmus, and therefore I will be able to measure the actual endocervical length and exclude it. Because otherwise, if you include that, then there will be a 4 to 5 centimeters cervical length, and that is actually not very helpful. And in my practice, I've learned that strangely enough, in the Chinese population, the cervix is extremely curved in almost all our patients at that time point. And so, of course, if you have a very curved cervix, and if you measure it with a straight line, then I cannot actually differentiate a short cervix from a long cervix, because when you have a curved cervix, which is relatively long, then I take the linear measurement. So I in my work, I haven't really been able to demonstrate the usage of cervical length for the prediction of preterm birth. But I think it might be helpful. I think for patients with symptoms, and I think it could be helpful for patients with previous history of preterm birth. And I think sometimes you would need to start measuring from 12 weeks if someone has had a second trimester miscarriage at 15, 16 weeks, because that might be able to help guide an ultrasound indicated cervical cerclage.
Okay, that's fine. Rabi, you have anything to say about that?
Yeah, the same for me. So if there is a patient on the screening conditions, I will not focus on the cervix. I will look at the cervix to see the relationship. Where is the placenta? Because some, especially for people doing abdominal ultrasound, vaginal is even more difficult. So they look at the placenta and they think if the placenta is there, it's anterior, but you should seek for the cervix in order to know if it's the cervix here, the placenta will be posterior, or they're anterior. And then I'll see the relationship to the placenta. The second group of patients are the one having cesarean section. I will look carefully if there is any relationship between the placenta and the cervix. And the third group of previous history. In previous history, I will measure, document, and tell them to have a close look a few weeks later at the doctor, or they can come back. So, I never saw a case of early shortening of the cervix, but rather 17, 18 weeks. There are some questions here in the audience again.
Probably before that, let me just quickly add one. How reliable is the assessment of placenta? The placenta, yes, in first trimester, because I know you talked about the fact that I also look at the placenta in your presentation.
The only
for overview anatomy of the placenta, but I don't think the reporting of placenta previa is helpful at all. For me, it's extremely, I'm very against it, because all women come along and say that I have a lower placenta, they're worried. I think it's actually not helpful for our women at that time point, so I don't report it.
The only condition, the only really condition is not the low-lying placenta. This does not exist, but let's say if you see the cervix and in front of the cervix only placenta, and let's say and you see where is the cervix. You say, I will check in second trimester for a previa.
And another point is
This is
relating
only
to the diagnosis.
this occurs once every third month, 4 months.
I think
But
we should focus on.
if we consider
sorry, cesarean section scar pregnancy. Just want to get that in, otherwise we'll forget. Anterior lower lumbar placenta, not placenta previa, anterior lower lumbar placenta in a patient with a previous cesarean delivery, then you should really be potential risk of cesarean section scar pregnancy, because that is obviously the condition itself is life-threatening for the patient, and therefore we must really make an effort to assess for that.
Yeah, that's fine. You took that essentially from my mouth. That was where I was about going to.
Sorry.
Because yesterday, those were the discussions yesterday about the issue of cesarean scar pregnancies. And so that's nice. I think there are some questions here.
Yeah.
Is it safe to do volume scan and Dopplers before 11 weeks gestation? Just on the issue of ultrasound safety and Lara.
Safe to do volume scan and Doppler. So there are two different modalities. Volume scan is a 2D scan, and it's even more safer to perform a volume than live scan, if you want, because you acquire a series of 2D images, and this is volume scan. It's provided you have used, let's say, a normal 2D preset. The Doppler, however, it depends what is Doppler. If it's pulse Doppler has by far more energy than color Doppler. Color Doppler has practically the same energy like 2D ultrasound if you know how to reduce the mechanical and thermal index. I personally do not do Doppler, pulse Doppler on the feet, on the embryo before 11 weeks. If I need to do it, I will do it on the umbilical cord. But I do occasionally color Doppler on the heart, even before, if I'm looking to a previous history at 10 weeks, I look at the four-chamber view. But I don't want to discuss this here because we are preparing in a small group new guidelines on scanning before 11 weeks, and this will be addressed anyway. Another question is on hematoma. Is subchorionic
hematoma? Yes. How relevant is the finding of subchorionic hematoma in first trimester scan? Professor Poon?
I think for me, obviously it depends on for me it depends on the size. It depends on the patient is symptomatic or not, and certainly we do know that there is association with pregnancy loss and placental complications. So I think if it's a substantial subchorionic hematoma, certainly want to reassure the patient that we need to consider. For me, I would do preeclampsia screening. That would obviously give me a sense of placental health, and then that would then further management. And if the patient is screened high risk for preeclampsia, then I could consider aspirin prophylaxis. But if somebody is asymptomatic with a very small hematoma, I wouldn't worry her at all.
I want to point to one aspect here, because this is something I see often. Patient coming, this is the second or third pregnancy, the doctor has seen behind the placenta a thickening, which is a normal contraction of the uterus. They assume it is bleeding. They let her stop doing any sports, any sex, and anything. And she comes, oh, I have a bleeding. Where have you bled? No, but the doctor saw bleeding, and you see the photos. No, there's not a bleeding. This was a contraction. So please be careful, because let's say the true subchorionic hematoma are so rare, because this you can see on the emergency in your place when your patient is coming with bleeding and you see something. Otherwise, the true bleedings are almost all under the amnion, and these are probably more dangerous. But this is life; you cannot do anything else. So, but I want to let's say warn you: please do not interpret in some uterine contractions or in multipare or in presence of fibroma a wrong hematoma. It is not. It is wait and check half an hour later it had disappeared.
I think Rabi has just spoken on something that's quite relevant, especially in an environment with the high incidence of uterine fibroids, whereby
we will have to close the session if That's okay. I think we've just lost Higa. I mean, Ravi, do you have any final words for us?
No, I want
audience?
to. There was two quick questions on if
Yeah.
we measure the nasal bone and frontomaxillary facial angle routine. I do measure the nasal bone routinely to oblige myself to measure it.
Yeah.
To that scene. The FMF angle I don't measure since years.
Yeah, same.
The other question, if we see the markers abdominally, are we still mandatory to do transvaginal? Definitely not. I put in my presentation the two aspects. I hope I was able to show you that if you have done the checklist abdominally, you don't need to do it. But I know that many people prefer to add on transvaginal because they see better. It's fine. It's fine.
Yep. Thank you so much, Ravi. And Higa, thank you so much. Despite the issue with internet connection, you've been fantastic.
Yeah, thanks.
May I ask you to introduce the next session? Thank you.
Yeah. So the next session will be on screening and prevention of preterm death, another extremely important topic in OBGYN practice. We'll be having our experts, Fabricio da Silva Costa from Australia, Conrado Coutinho from Brazil, and Catalina Valencia from Colombia. So I'll be handing over to them to continue this session 5 on screening and prevention of preterm death. You're welcome, please.
Thank you.